All right, well, good morning, everyone. Welcome to this webinar co-hosted by UTSA and UNS, or Civil Marat University in Indonesia. My name is Eric Shattuck. I am the Interim Director for the Institute for Health Disparities Research here at UTSA, and also a member of the Department of Public Health. I'm going to be moderating today's discussion and also keeping an eye on the waiting room and the chat and any questions and things like that. So we are currently recording this. When we get to the Q&A, feel free to put your question in the chat. Feel free also to raise your hand and unmute yourself when I call on you. We are joined today by our panelists from UTSA. We have Dr. Caitlin Cilio, who's a member of the Department of Public Health. She works on gender and HIV/AIDS in Uganda with men in particular. We have Dr. Nutria, who is in the Department of Obstetrics and Gynecology at Mawardi Hospital and Civil Marat University. And also Dr. Dani, who is also affiliated with Mawardi Hospital. Excuse me, it's very early in the morning and I'm only on my second cup of coffee. And he's also affiliated with Civil Marat University. I hope everyone has had a chance to watch the webinars that were posted on YouTube. We had, I think, a really great kind of cross-section of current topics in HIV/AIDS. And I'm hoping that we can have a really wonderful and productive discussion. I'm also joined by Dr. Widana, also of UNS, who I may ask to help me monitor questions and things like that as they come in. And we are also joined by Dr. Shamshad Khan from the Department of Communications here at UTSA. Dr. Khan conducts research on HIV/AIDS and stigma in India, and he's joining us as a discussant today. So welcome everybody, and let's go ahead and get started. All right. So let me open it up to the floor and see if there are any questions. I know that I have some, and so does Dr. Widana, that we came up with after watching the videos. Again, please feel free to put your question in the chat box or raise your hand. All right. Doesn't look like we have any questions from the floor just yet. One question that I thought was particularly salient right now, given the current COVID situation, and maybe I can ask this of Dr. Dani. Your talk focused on HIV in the context of COVID. Do you think, or what aspects of Indonesia's response to HIV/AIDS over the past few decades, what lessons have been learned and have those lessons been able to be applied to COVID?
Okay, thank you, Mr. Eric. In Indonesia, we have many problems in HIV program in patient. Some of the problems that arise as the time lack of understand of patient and the public about modes of transmission and prevention, maybe lack of understand of health worker on effort to control HIV infection, maybe lack to integrated HIV service, maybe reducing the risk of stigma. In Indonesia, stigma is main problem. Maybe the number of HIV tests is carried out, and maybe the stigma is still low. So many problem in Indonesia in the use of condom is major problem in my country. Maybe this.
Yeah, and I wonder if we're seeing similar aspects of stigma with COVID-19. My guess is probably not nearly to the same degree, right? Because there's not that aspect of sex or drug use and things like that. But certainly for particularly vulnerable populations who have gone through, the HIV/AIDS epidemic, maybe becoming less trustworthy of doctors and medical facilities and things like that. So maybe that's preventing coming in to get tested for COVID and things like that. Dr. Khan, maybe we could ask you your perspective on stigma, since I know you do a lot of work with that in India. Do you see a lot of the same issues of stigma as Dr. Dani's mentioned in Indonesia? What are the commonalities and differences as you see them?
With regard to HIV/AIDS?
Yes.
Well, first of all, thank you all for joining in, and it was truly a privilege to have the opportunity to listen to wonderful presentations here. I think that some of the issues that are being highlighted here are the persistent challenges we have in our struggle against HIV/AIDS and the emerging new challenges, which I think Dr. Dani's presentation has brought forth, right? The complications that we now have with COVID-19 and the emerging new infections, which I think President Biden today is going to address in his remark as well on World AIDS Day. With regard to the stigma, at the center of HIV/AIDS, and perhaps for most of the public health issues, what remains is the structural dimensions that we encounter. I think Dr. Celio's work speaks to that in many ways. We cannot really understand a complex problem by adopting just one single approach to it. Stigma, in fact, is also something that needs to be addressed in the same way. If you look at stigma with regard to HIV/AIDS, my work has, I've learned doing research, with the communities that we work with, it is grounded in multiple layers that you can see. I mean, one, of course, is the simplistic way of saying, well, I'm afraid of HIV/AIDS, therefore I do not want to engage with you. And therefore you can, reduce that to the level of lack of awareness or, cognitive, approaches that you can adopt to deal with that. And that has been, unfortunately, a dominant approach for a long period of time. If we can address, lack of knowledge by spreading more information about HIV/AIDS, stigma will go away. And that is unfortunately not the case. What my research shows is that, in fact, people who live with HIV/AIDS, and if you look at where they're discriminated most, it happens within the healthcare setting, and it happens within family. Now, your logic will say that these are the people who should be the most informed people, either by having studied, or being oriented to HIV/AIDS, or by living with people, who are, having that syndrome, right? And yet it happens, in fact, research after research shows that people who live with HIV/AIDS are mostly discriminated within these, settings, right? And so how do we understand that? How could people who provide care and support, right? These are doctors, these are nurses, these are paramedics who are supposed to be knowing, right, how HIV/AIDS spreads and what are the ways to take precautions, could still be stigmatizing or discriminating against people who are living with the condition. So at the center of it is power inequality, right? That we are talking about. The class, the gender, the race. I mean, these are the dimensions that really need to be addressed, right? So in India, for example, most of these people who live with HIV, they go to the government healthcare settings. And of course, these, I'm not saying that these doctors and nurses, they're demons and they should be demonized. No, they are overworked. They are working, with so many people. I mean, Dr. Celio's work can speak to that in Uganda. And, these are well-meaning people, but at the same time, they're overwhelmed. And the dominant discourses that you have in society, right, with regard to those who are afflicted with HIV/AIDS, who are these people? These are sex workers, injection drug users, men who have sex with men, and then the dominant discourse is, well, they are responsible for it. Why did you do that kind of work, right? Why do you inject drugs? So there are multiple layers, what I'm talking about, that somehow, go on to shape our understanding of the disease and those who are afflicted with it, and the way we respond, to them. So, how do we deal with that? Again, I think Dr. Celio's work speaks to that. We have to have an ecological approach, as she points out. And I'm trying to connect it to the presentation here, right? So the stigma too, needs to be addressed at those multiple levels. Policy, of course, from individualistic point of view, that is important too. We need to continue to have that conversation. But I think we need to go beyond that to talk about interpersonal, family, healthcare settings, policy dimensions, gender issues, right? And in the context of United States, race, is again, significant. So, because you would be surprised, even in the United States, there have been studies, almost 40% of the people still feel uncomfortable working with or doing any kind of business with those who are living with HIV. So, I mean, I just wanted to talk about that. So in India, it's even worse. They did studies, and majority of the population, they felt that they were uncomfortable, working with or living with people who were HIV positive. Does that speak to that, Eric? And I would leave it for others to comment on.
Yes, absolutely. Thank you, Dr. Khan. Yeah, and I think Dr. Celio's work and her presentation gives us a really good kind of foundation to think about that kind of ecological model and addressing these issues across multiple levels, because, as we see with so many problems in the world today, right, whether that's related to health, COVID-19, HIV/AIDS, or climate and climate change and things like that, it's not sufficient to just address it at one level. It has to be part of a larger push across multiple levels to actually enact the changes that we need to see. Dr. Celio, maybe we could ask you a little bit more about stigma in Uganda as it relates to your work and Dr. Khan's comments.
Sure. Yeah. Thank you so much, Eric, for moderating, our UNS collaborators, Dr. Khan, for your insights. Sorry, the sun is really coming in on me now. Let me rearrange. That's good. Yeah. So actually, I think the stigma piece is really interesting as it intersects with gender. I think it is almost, they're really entwined in terms of like masculine norms and men's engagement in care and stigma. When you talk to men in Uganda, and I think it's probably similar in Indonesia and India and in the United States, when there is hesitancy to come and engage in HIV care or stay engaged or take an HIV test, you can really link it to both stigma and gender norms, because that fear that HIV is going to have some kind of negative social consequence on their life, their relationships with other people, their reputation in the community, that is all fear of stigma, but it also is really tied to their masculine identity. So that fear that HIV is going to negatively hurt their masculine roles, their role in their family, their relationships with, their intimate relationships with partners, their respect in the community. So I think a lot of my work, around gender norms, stigma is almost always like right at the center of, and what we're doing in Uganda, I think it is, there's that, I don't know why it's the first thing we think to do that individual level intervention, right? Where we want, oh, this person has issues with stigma, or, they need to understand that HIV won't hurt their masculine norms or roles, but could actually rebuild their status or help them, continue to fulfill their roles. I mean, that is one approach at the individual level. But what we're trying to do is move away from that individual level and look at the health system and look at, providers and how that interaction and those power dynamics, how gender influences the relationship between providers and patients, and how gender intersects in those power dynamics. Because there's like the status of being a health worker, then there you add, a lot of other layers of power, as Dr. Khan was mentioning. And how can we, sort of create a program that would help, at the health system level to reduce stigmatizing interactions between providers and patients. And in that regard, also help to address some of these gender issues that I think are just intertwined, as I mentioned. So yeah, I think what we're doing is a program for healthcare providers that we call gender transformative, to help them understand gender norms, to help them understand how gender norms influence patient interactions, but also to look at their relationships, themselves, their own biases, and how that influences their interactions with patients. And then there's sort of the higher level of how are the programs set up? I mean, there's just structural issues, like with the HIV clinic being its own separate, clearly the clinic for HIV patients, that causes a lot of issues and makes, men in particular not come to care because it will identify them as HIV positive, so they'll end up going to a clinic further away. So there's a lot of multi-level approaches that need to be taken, and then of course the broader just attitudes towards people living with HIV, kind of at the community level. And so community campaigns and things, I think, can help address that. But I do think the more, what we've seen in Uganda, the more access there is to treatment, and the more that's known, and that like HIV is not a death sentence. There are drugs available that are effective and will keep you living healthy. I think once that is known and understood by a community, stigma starts to reduce. And so, obviously the goal is to have universal access to HIV treatment to begin with, but I think there are positive effects on stigma as well. So let me stop there and allow others to jump into the conversation.
Thanks, Dr. Cilio. And yes, please, for all of our participants, again, feel free to drop your questions in the chat or raise your hand using the raise hand function, and we'll call on you. Maybe we can move to Dr. Nutria. In your talk, you mentioned that in 2018, the largest group of HIV/AIDS cases in Indonesia was among housewives. And that of course leads to the risk of vertical transmission to the child. I was curious about, since we're talking about stigma, how does stigma play into this group, the housewives? Because they're not, I imagine, I hate to say responsible, but I imagine it's the behavior of the husbands that leads to their infection with HIV/AIDS, right? So it's kind of a secondhand stigma, perhaps. And so I wonder if you could talk a little bit about that, and perhaps how you see stigma impacting your work there at the hospital and in the clinic.
Okay, thank you, Dr. Eric Stuck. Yeah, maybe in Indonesia, the stigma is a little bit different in here. Maybe the stigma in here is for the 62% that the our public that didn't want to contact with the HIV patient, and also the health worker, they are worried or maybe they are afraid to be contact with the HIV patient. So the treatment, or maybe based on that stigma, so the treatment or maybe the management of the HIV in pregnancy from the healthcare workers from the primary is not still not optimal. And when the mother or the household mother is in a HIV positive, so maybe they didn't want to get to know with the mother, and like maybe they have to refer in a tertiary care. From base of that, so maybe the housewife mother becomes stressful, and it's affect on the pregnancy. Maybe something like that. And in the era of pandemic era of COVID-19, maybe in Indonesia there is a rising increase the people with HIV, especially in the mother, because we have like social distancing program or work from home. So in here maybe there is no routinity. So maybe it's affect the sex behavior, and affect that there is a lot of pregnant mother in here because of the effect of work from home. So if the mother is increasingly spreading, the HIV also increase, because we have a test in a mother, in a pregnant woman. So if they get the test of HIV, including if they are having hospitalized in COVID, so they have to check with the HIV status too. And then from that, we know that the HIV patient, especially on pregnant woman, is increased too. I think like that. Thank you.
Dr. Nutri, if I could ask a follow-up question. In Uganda, we find that in terms of engaging individuals in care, a big issue is some relationship issues between men and women. So issues with getting couples to disclose to one another, fear that, this kind of comes back to stigma again, but fear of abandonment from your partner. And so we do find a lot of engaging women in ANC and, preventing mother-to-child transmission. A lot of times our approaches are trying to also engage the man so that there's support for the woman to be there. So I'm wondering if that's a similar dynamic, or what that is like in Indonesia.
Okay. In Indonesia, it's tend to that the woman is being not really supported by his man, not really supported by his husband, but by her husband or the family. So sometimes if they have a positive mother, and then we get the ARV treatment, and when the baby is born, and then the status of the baby is negative, we are maybe afraid, or maybe the women afraid to explain to the host to their husband how can it be transmitted from where, because maybe if the woman is positive, the husband didn't want to check the HIV status. Yeah, they refuse it, the man. Something like that.
Yeah, and Dr. Nutria, this was, I think Dr. Celia really asked pertinent question there, and you tried to. I mean, we can only give some of these explanations that that are approximate explanations. It's so hard to, get to the bottom of it. But there is something definitely going on in terms of the gender dimension, and the structure, issues that we have there. For example, in your presentation, you beautifully presented here saying that, while the ANC coverage in Indonesia is almost like 93%, which is pretty good, not meeting the target 100%, but it is there. But HIV testing is only about 25%. So these women are going for ANC, but they're not being tested for, HIV. And then those who are being tested, and if they're HIV positive, if I'm correct, you're saying that only 13% of them are put on ARV. And so, first of all, how do we understand that gap? So even when they're going to, and there is a policy in place, as per your presentation, that, we should have 90% of these women, right, tested for HIV. So they're going to the care facility and yet not being tested for HIV. So either there is something, at the level of family where there is not much support or lack of awareness or whatever that might be, or a mix of all that, or there's a lack of priority within the healthcare setting where the care providers feel like this is not important, right? And so you have been taking care of ANC. I mean, all those, the vital symptoms, and then they're not really caring too much about HIV testing, despite the fact that there is a policy in place. I mean, how do we understand that?
Yeah, thank you. And I think the most of them, especially in pregnant women, they refuse at first because they afraid for the result. If their result is positive, so they are afraid for the stigma and didn't have any support from the family, especially from the husband. In Indonesia, maybe our country is much more in a rural area or village, and in the village, if they know that the status of the mother is HIV positive, so they will be didn't have any support from any family. So maybe it's mixed from the lack of the awareness, and also maybe the main problem is they are afraid for the result, and if the result is positive, they didn't want to come to primary healthcare again, and maybe didn't want to get the therapy. So we as a healthcare worker, that we have go to door to explain and to give a maybe educate for the family or for the pregnant women to get to the ARV, and also to continue the treatment for HIV.
That's awesome. So that tells me again, and I'm just jumping in. So this is a research domain that opens up, right? Trying to explore. So it seems like, and of course, healthcare workers, based on what you're saying, they cannot insist on HIV testing if women don't want to do it, right? So there has to be full disclosure. They have to give the consent, and therefore they should be tested. And if they don't give the consent, you cannot really test them, right? I mean, if they follow that norm, then we have to understand why they're not. And it seems like, you say you're pointing to the gender dimension and the whole fear and anxiety and stigma and everything. This needs to be, I'm not sure if there are studies and, that have been done in this area, and probably needs to be further research. How do we understand that gap?
Maybe now we have to do a lot of education also in a healthcare workers to maybe more know, or maybe more discipline to the stigma that maybe not all of the healthcare workers know very well about how to transmit or how to spread the disease, and they just very afraid. Yeah, and if they have a HIV patient, they tend to refer to us in maybe in tertiary facility. not in a primary care. So if in a village or rural area, they have maybe like midwife village, bidan desa, we call it, that maybe they don't want to get the HIV too, they are afraid. So something like maybe education or a study for them, especially for healthcare workers in the village, that we want to educate them so they are not very afraid anymore and can be a healthcare worker that maybe can support the in the rural area.
Yeah, actually, I read also in a presentation about training for the healthcare workers, especially in tackling the gender inequality or stigma in Uganda. Can you please explain further about the training for the healthcare workers, because it's related to the problems that Dr. Nutria mentioned earlier?
Sure. I mean, I think one difference, and this is not the training, but it's coming higher from the Ministry of Health and at the national level, is, you know, women get tested for HIV in ANC in Uganda. You know, that is very universally implemented. And so I think that that is coming from high up, it's high priority. And so, you know, actually getting identified who are HIV positive in ANC and then getting them on treatment is very well done in Uganda. I think, again, because that is very much part of their national approach and very, very supported. It has caused some of this gap we see in men's engagement in care that my presentation is alluding to, in that there is not the same sort of structural intervention to get men tested that as there are for women. And that's because of pregnancy, women just, you know, there's that opportunity to do it. So I think these structural approaches to find those opportunities and then make sure that they're, you know, high priority and implemented is really, as Dr. Khan is talking about, that high level approach that has a really far reach. But yeah, and then in terms of my research, we are focusing on creating an intervention that would train, you know, focus on the providers themselves and their understanding of gender issues as it relates to these disparities we see in HIV care engagement. So it's a program we're creating based on qualitative research that we've done and we'll be testing, you know, in a pilot intervention. But yeah, the idea is that, you know, if we can increase the provider's understanding of gender specific and gender sensitive ways to engage with men and women, their empathy and their motivation to respond to that, which I think really does come down to reducing those stigmatizing interactions. You know, particularly men, when in this relationship with a provider, they're in sort of a subordinate position, taking instruction from someone else might kind of go against, you know, what they're the kind of role they're expected to be in as a man, especially if it's a female provider, which tends to be the case. So how that provider approaches the man is really key in kind of getting them to stay in care and stay engaged. So that's sort of one example of that element.
Yes, thank you.
Yeah, thank you. So we have a question in the chat from Ulia, who asks, what can we do, particularly in Indonesia, what strategies are there so that Indonesian men are paid just as much attention when it comes to HIV/AIDS as women are, since the government seems to pay more attention to pregnant women. It's easier to test pregnant women when they come in for antenatal care, although as Dr. Khan and Dr. Nutria have discussed, you know, sometimes there's not that exact, you know, kind of one-to-one testing for everyone coming into care that we might like to see. So what strategies are there so that healthcare workers and everyone can pay more attention to men and regardless of the gender of the healthcare workers, what can be done there? And I suppose that's for Dr. Nutria and Dr. Dani.
Okay, maybe I'll try to answer first. Maybe I'd like to explain first for the background why in Indonesia maybe the test is more easier in women, yeah, because the background in Indonesia there are many new cases HIV in children under 15 that we presume that it is caused by the infection long time ago. Maybe it's acquired during the infancy or maybe from the undetected HIV mother. So that for global eradication for the vertical transmission in pregnancy, the focus is for the pregnant women. So all of pregnant women is have to be checked that are tested for HIV in the first antenatal care visit. Actually, if from the government program, if the mother is positive, the woman is positive, the family, also the husband is should be tested also, but maybe because of the stigma or lack of the knowledge, they often refuse the men. If we know from the mother, so the husband is often to refuse to get checked. Maybe like that. From Dr. Dani, maybe want to add some opinion. Maybe Dr. Dani.
Yeah. Thank you, Dr. Nutria. The stigma in Indonesia cause a lack of care from the family on the community around them. Then this causes the patient to feel alone and has no friend, and so the patient does not want to come to hospital or treatment or counseling. In policy of government in Indonesia, for pregnant women are tested for HIV. So maybe this program maybe is good. So we can get to HIV patient for the pregnant woman. Maybe this, Mr. Nutria.
I can share a few things they're doing in Uganda as well to engage men. In the clinics we were working with, they had what they called male champions. So it's sort of like a peer educator or, expert client, but particularly, aim to help engage men after testing, to talk to men, to be there as like moral support and a role model, someone who's also living with HIV, also has engaged in treatment. And then I think they're also, sort of engaged with the village health team, which is like Uganda's community health worker, to do targeted testing in the community in venues and at times when men are more likely to be found. So, there might be like boda drivers, motorcycle taxis, and doing, targeted testing around, their taxi stages, for example. And then there's also what they call moonlight clinics, where they have testing or treatment available in the evening or available on the weekends, because a major barrier for men's engagement is the conflict with work. So that's another approach. That being said, a lot of these things are inconsistently implemented. They obviously need a lot of funding. There needs to be that priority at the sort of district and national level to support those types of programs. But we are seeing more of that, and I think it helps. But there are a lot of barriers still, and there needs to be, I think, community mobilization that pairs with that. So my other research in Uganda focuses on family planning. and male engagement in that regard is very similar in that women, want to use contraceptives and often use them in secret or don't use them because their partner refuses. So engaging men is really important. And in the rural community that we're working in, we're doing sort of community dialogues that are meant to sensitize the community around family planning acceptance, address some of these gender inequities and these gender norms that drive, the idea that families need to be very large, in order to have status in the community. And I think that approach has been used for HIV, and it has a lot of potential for engaging men in particular. Again, getting at sort of the community level stigma. I think Dr. Khan, maybe your work is similar to that. I'd love to hear a little bit more about it.
Right. And I'm so glad that, some of those things are being done in Uganda as well. One of the things, and I'm sorry about my puppy who might be hearing his bark off and on. It's one of the things that we have learned doing our research, and the interventions are in the early stages, which relate to engaging men. What it comes out from Dr. Nutria and your presentation as well, you touched upon very well. We can't really address a complex problem like HIV/AIDS without engaging men. And particularly in the context of gender. When we think about gender, we think about, okay, women need to be, addressed, and how do you do that? You can't do that without really addressing men, because they're the ones who are often, part of that oppression, or however you treat it. And so if masculinity is at the center of it, if patriarchy is at the center of it, then you have to engage them to address that, to understand that in those micro spaces, how it works, right? So we have to do research and understand what are the ways in which, masculinity is manifested, in the community, at the level of healthcare setting, in policy discourses, in the mass media, and then intervene in those spaces. It has to be really tailored, right? And also look at some of our HIV/AIDS interventions and the campaigns that we have designed. My work has shown that mass media campaigns in India for a long period of time, in order to address HIV/AIDS, actually ended up perpetuating patriarchy and masculinity, which is at the center of it. So it's like, all well-meaning people wanting to do good and not realizing that HIV/AIDS campaigns, in fact, perpetuated patriarchy for a long period of time. Right? And so we need to understand, where the problems are. I wrote that paper called Manufacturing Consent almost, 8-9 years ago. And I looked at, the mainstream HIV/AIDS campaign in India, which was sponsored by NACO, National AIDS Control Organization. And if you look at those, early, and even now, some of them, how, and public health, and I'm sorry to say that, public health folks, our training and education is so narrow that we often don't really think about some of these complexities, right? And how we think about saving lives, we think about, raising awareness, we think about studying, how the infections spread, but we don't really understand what are the structural conditions that really facilitate those. So one of the things that we are doing in Karnataka, for example, and that's again is very narrow, because we often want evidence, right? And then that makes it narrow. That's a complex debate to have, right? Is couple counseling, right? Bringing men and women together, in different spaces at different points in time, and having a conversation around some of these dominant issues. It could be around HIV/AIDS, but then also confronting issues of stigma and gender and the relationship that they have. So they would have couple counseling. They would have events where they would, bring these people. But my work is mainly in the area of, high-risk groups. So I don't work with housewives. My work is mostly on sexual minorities, sex workers, MSM, and so forth. So they are doing some of those interventions. There are some interventions that are happening at the community level, engaging teenagers, through sports-oriented program, confronting, gender and masculinity, dominant gender norms and masculinity, having champions, as you talked about, men, becoming advocates, and so, but these are really minuscule efforts, because for a long period of time, people said, where is the evidence, right? And it's too much. Can we have something more tailored, because we want results, right? And so, but people have begun to realize, in fact, if you look at UNH slogans and the press release that they just came out with, it's called End Inequalities, End AIDS, End Pandemics. And exactly what we are talking about right now. And they're saying, unless we really address structural, inequalities in society, we are not going to end AIDS by 2030 that we have talked about. So that speaks to that. So slowly the momentum is growing, and hopefully more interventions will happen. But we are far from it. Including in India, where in fact India is being showcased as a success story. But I'm sorry to say that it has mostly been very much behavior centered intervention that they have done.
Thank you, Dr. Khan. Thanks also to all of our panelists. Really fascinating discussion. We're coming up on about the 10-minute mark left in our hour. And we have a question in the chat from Tanya, and I think I'm going to expand on their question, since we've just touched on, the drive to end HIV/AIDS by 2030 and so on. 2030 will be here sooner than I think all of us would like it to be, for any number of reasons. And we find ourselves, of course, now caught in another pandemic of COVID-19. So Tanya's question is, what are the causes of the increase in HIV cases during COVID-19 in Indonesia, over the past 2 years, as Dr. Nutria and Dr. Dani have highlighted in their talks? And then the follow-up to that is, what's the solutions that have been planned to overcome this issue? And I could expand on that a little bit more by asking too of Dr. Cilio and Dr. Khan, and the rest of our panelists as well. Are we seeing similar increases in India and Uganda? And I know that none of us have a crystal ball and none of us are perfect prognosticators, but what do you see as the impact of COVID-19 on the drive to eradicate, eliminate, reduce HIV/AIDS in your respective field sites, Indonesia, Uganda, and India?
Go ahead.
I think it was highlighted in your talk, that correlation that we're seeing, if it is a correlation.
Yeah, probably Dr. Dani.
Okay, thank you. Thank you for Tanya. In Indonesia, HIV patient in Indonesia usually come to in the hospital in stage 3 or 3 or 4 condition with CD4 below 50. So that there are many opportunistic infection that makes the prognosis worse, and the morbidity and mortality is high. Lack the information and understanding about HIV is one of the cases in the problem. After the implementation of the new normal rules and the application of health protocol to health facilities in COVID pandemic in now, you can see in my presentation the discovery on the new person living with HIV in 2020, and the beginning of the first quarter was higher than 2019 in April and decreased, but in June saw an increase in new case. This is a comparison of new cases in the same month before and during the pandemic. People with HIV are at high risk to getting infected with COVID-19. Soon the problem with the human system and the virus mutation. This has led to increase of cases in Indonesia, maybe in the world.
Uganda, I don't think we've seen the same, rise in HIV cases during the pandemic that I'm aware of. But from my research, what we have found, this was research specific to kind of unintended pregnancy and family planning use during COVID-19 lockdown. So Uganda, while it hasn't had as high of a burden of COVID as other countries and other regions of the world, it has had multiple pretty strict lockdowns, stay-at-home orders, bans on transportation, which has put people in their homes for extended periods of time. And we qualitatively have reports of increased intimate partner violence due to that. Again, coming back to this gender inequity issue, more sex happening between partners because of that. And again, women sort of having less say over the circumstances and timing of sex with a husband. So you're, seeing more of that. So there is this expectation that that COVID might lead to an increase in unintended pregnancy, which obviously has implications for HIV transmission if, in that same regard. So I think in terms of, how it intersects that there's that. And then of course, as highlighted in Dr. Danny's presentation, there's issues with, getting to the clinic if you are living with HIV, resources behind, resources being diverted maybe to control COVID that would have gone to HIV prevention and control. And a lot of issues with, actually getting to the clinic and getting your treatment, in the case of a lockdown or in the case of an outbreak. Maybe Dr. Khan can continue, with his insights from India.
Yeah, thank you very much. And I, looking at the impact of COVID-19 and in terms of data that can speak to the impact, I have similar, situation there. Often epidemiological figures, in India, they lag behind. So they collect it and it's almost like 2 years behind, right? So, and we're having this COVID-19. And so, you don't have, the enough data to really speak to that. But what you see is being reported in the news media, and then you see, what's happening on the ground. Some of the concerns that Dr. Dhani's presentation actually, raised are similar in India too. What you pointed out, Dr. Dhani, is that only about 50% of those living with HIV had access or had gotten, the COVID vaccine, right, from your presentation. And I'm thinking that's pretty impressive, given that these people are actually, aware of their vulnerability and the complications that, COVID-19 can do. In case of India, if you look at the figures, only about 30% of the population is fully vaccinated. And we don't have the figures about how many of them are people living with HIV. What is the access to? There is no way to really speak to that for now. But we do know that given that most of them happen to be on the margins of society, their access to COVID-19 vaccine have been deeply impacted, partly because most of the interventions in India happen to be community-based interventions, not because the government would like it, because historically they have been forced to engage in community-based interventions because that was the only way to access these hard-to-reach communities, right? And these community-based interventions have been deeply impacted because of the COVID-19 situation. So, you do not have as much of community outreach, the connection to services, testing, ARV support, And there have been news media reports whereby there were lack of adherence to ARV care and support because people were not able to go to the clinics. Many of them were not available, and so it's really a big problem. They're trying to fix it. My sense is that the targets that we have definitely, we are off track, and that's the big picture overall that we can think about. Community-based interventions have been deeply impacted. There have been some calls from my community groups that actually these so-called, marginalized groups are empowered enough to take COVID-19, and HIV/AIDS together, and work on it. They are empowered enough. My community that I work with, they said that we can really do that. We can deliver that. Whether it comes to spreading the information about COVID-19 and HIV/AIDS together or providing access to vaccine, why are we not on the front of it, front and center of it? But that has not happened. Those calls have also been from, Ashodhya sex workers community that I work with. They have made those kinds of calls that we can be at the center of it. We can deliver the services. I don't know if that addresses the point that we're trying to. But partially, at least, we know what's happening.
Yeah, thank you, everybody. I think it's fascinating to think and unfortunate in some ways that the people who have spent the last, or the communities, the groups that have spent the last 20, 30 years, generation now, living through HIV/AIDS are ones that in some ways are maybe best prepared for this current pandemic, and I hate to say any future pandemics as well. And I think that's a really, really fascinating and potentially impactful connection to be made there, right? What can we learn as public health practitioners, as clinicians, and so on, from the groups that have lived through this? Yeah, absolutely. And in these kinds of wicked problems, as they call them, right? We need all the help we can get. We need all the solutions, and we need to be working together. We're coming up to the hour, so just kind of a final thought from me, and then maybe we can open it up for any final thoughts from the panelists. But talking of working together, I think it's great that we were able to bring so many people together in this webinar who work in different geographic regions where the conditions are different, but in many ways, right, very often the same. And you may have seen on UTSA Today's webpage yesterday that UTSA and UNS have formalized their relationship and their partnership through memoranda of understanding and things like that. So I think this is only the beginning of all of our work together between UTSA and UNS, and I'm excited to see what comes from it. So my thanks again to all of the panelists and speakers. My thanks to the audience. Let me open it up for any final thoughts from our panelists and from Dr. Wadana.
Yeah, I just want to say thank you for having us. I think, as Eric said, I'm very much looking forward to continuing the relationship with UNS, and I think there's lots of overlap between our work, and of course, lots to be done, as we've highlighted today. So thanks everyone for attending.
Yeah, too. Thank you very much for including us in this kind of fascinating discussion tonight, and it's a lot of knowledge that we can get from the discussion, and I believe all the participants also feel the same way, and looking forward for the next event, perhaps the end of the year or next year. We will wait, and from Dr. Samsat as well, from another perspective from India, like we are in the same region, Asia, perhaps we can cooperate and doing something about this issue, especially on HIV/AIDS. Perhaps another closing statement from Dr. Nutria or Dr. Danny.
Absolutely, it is quite a privilege. And as I said, it was wonderful to listen to the presentations. I could already see quite a few spaces where research and interventions need to happen. And so I'm excited and be happy to collaborate and help. So thank you for. And I'm glad to hear that UTSA has formalized, that relationship. We need to have more of that. That's awesome.
Yeah, thank you very much.
Yeah, thank you for Dr. Samsat, Dr. Kathleen, and Dr. Eric. We can discussion about HIV, and maybe we can continue this program with Dr. Widana. We can make a project, maybe make a project, make project again. Okay, thank you.
Yeah, maybe I also want to say thank you to Dr. Kathleen, Dr. Samsat Khan, and also Dr. Eric and Dr. Dani, also to Dr. Widana for the opportunity. And we have a good knowledge and discussion tonight for about the strengthen the healthcare system for global eradication of maybe vertical HIV transmission, especially in pregnant women. I hope we can go to collaborate next time. Thank you all. Thank you.
All right, thank you all very much for your time and attention and the wonderful discussion and questions. Obviously, there's a lot more work to be done, and this is just the beginning. Everybody have a great rest of your day, whether you're here in the United States just getting started with it or there in Indonesia winding down for the evening. Thank you all very much, and we'll try to make this recording available to everybody as well. Thank you again, and take care.
Yeah, thank you very much.
Thank you.
Thank you. Take care.
Bye-bye.